Okay. So 2:30, we are perfect in time. We can start the new session, infection and instability. So let's start with Giuseppe Umile Longo, how to diagnose an infection after shoulder replacement.
So, good morning everybody. Thank you Francesco for the kind invitation to give this talk. First of all, I would like to start from this paper that we published together with my friend Alex Castagna and Enrico Guerra. We described the shoulder replacement incidence in a 10-year period in Italy, based on the discharge chart from the hospitals in Italy. We found, you can see a great increase in the number of procedures performed in the last 10 years. And we performed in Italy 73,000 procedures. Of this, there were 2,129 revision surgeries performed. In the case of revision, the number of female it reduced compared to primary cases, and the majority of cases is performed in patients between 70 and 80-year-old. Causes of revision: dislocation of prosthetic joint in about 17% of the cases, 13% mechanical complication, mechanical loosening 10%, infection 6% of cases. In this paper, we described instead the correct antibiotic prophylaxis that should be performed in primary and revision shoulder replacement, the differences, the causes. We saw that the most common bacteria responsible for most PJIs are Propionibacterium acnes, Staphylococcus aureus, Staphylococcus epidermidis, and Coagulase negative Staphylococcus. And this is important when we consider how to perform the correct prophylaxis. But these bacteria are really different from the ones that affect hip and knee prosthesis. Of course, when we refer to criteria to perform a diagnosis, we must refer to the International Consensus Meeting. We participated to this consensus. I wrote a book on infection and knee replacement after the consensus with my friend S.r.l, a great expert in the field of infection in joint replacement. But when we refer to the shoulder, the criteria and the characteristics are different compared to shoulder, to knee and hip. These are the three major criteria for an infected shoulder prosthesis. So, sinus tract to joint, two same positive cultures of virulent organisms, and gross pus. For the weighted score of minor criteria, more than 6 with an organism, it's probably a PJI. Without more than 6, without an isolation of a bacteria, is a possible PJI. Two same positive cultures of a low virulence organism is a possible PJI. Instead, negative cultures or one positive of a low virulence organism is an unlikely PJI infection. So the minor criteria you see on the right side of the slide, the weight from 4 to 1. And these are unexpected wound drainage, single positive tissue culture of a virulent organism, single positive tissue culture of a low virulence organism, second positive tissue culture of an identical low virulence organism, but you see it's different the weight, humeral loosening, 3, positive frozen section, positive preoperative aspirate culture, elevated synovial neutrophil percentage, elevated synovial white blood cells, elevated ESR, elevated CRP, elevated synovial alpha defensin, and cloudy fluid. So about the workout, when we start from ECR and CPR, if they are abnormal or we have positive aspiration bone scan, then the intraoperative decision is important. In the cases of normal ECR and CRP, it's important to consider imaging, examination, aspiration, and eventually we can go for a single stage revision. What can we say from clinical examination? The consensus in Philadelphia agreed 100% about the presence of a sinus tract, which is the only clinical sign that can be considered highly specific for shoulder PJI. Regarding the imaging, radiographic findings like loosening or migration, radiolucent lines, osteolysis and osteal scalloping and newborn formation, and specifically humeral loosening should significantly raise the suspicion of shoulder PJI. Regarding CRP and ECR are high they have high specificity, low sensitivity. No, there is not a rule in the clinical practice for next-gen PCR next-generation sequencing. And so I think that I must stop because it's 5 minutes. Thank you very much for your attention.
Next speaker is Giovanni Di Giacomo, how to manage infected arthroplasty 1 versus seconds.
I show to you how I live an infection. I live an infection in different way from the other complication of the shoulder pathology, because in other shoulder pathology, as we saw this morning, we see our enemy. It's the bone loss on the humerus, on the glenoid, is the dislocation, osteolysis. We can see with our eyes the enemy. Unfortunately, when we face with the infection, if we are lucky, we can see only the consequence of our enemy. So that's the reason I live like a match. In a match, we have the attack, that are the enemy, Staphylococcus, Cutibacterium acnes, and we have the defense, 1 stage, the breach, resection. This is defense, partial 1 stage, 2 stage. This is the way we can defend, also with the spacer, component stage. Then we have a referee, then we have a coach, and of course we have a score. Let's give a look. Who are the actors? Referee, attack, score, defense, coach. Who are the enemies? Staphylococcus epidermidis, Staphylococcus aureus, Cutibacterium acnes, everyone with some characteristics. The difference is 1 stage, partial 1 stage, the breed, 2 stage, components change, spacer resection. The coach is you, is the surgeon. You are the coach. And the referee? The referee is the literature. Is the only way we can help each other is looking at the experience of our colleagues around the world. And we are very lucky for this. Regarding the last point is the score. The previous lecture showed that there are major criteria, in this case it's very easy, and there are minor criteria. These are the minor criteria. There are minor criteria that are pre-op, other minor criteria that we can study during the surgery, and in some cases also the scope can be useful if you want to take some specimen. These are the minor criteria. Treatment. We have no arthroplasty option, the breed, antibiotic spacer, resection, and the other side we have an arthroplasty option. Regarding the arthroplasty option, we have modular exchange, 1 stage, 2 stage. 1 stage can be component exchange or complete removal or implant. 2 stage, antibiotic spacer and revision. Type of infection, likely virulent, likely indolent, unexpected post-operative culture. Likely virulent, usually the score is very high, around 7-8, and in my hand it works. I prefer to do 2 stage. Of course, using antibiotics for almost 6 weeks, monitoring everything, physical therapy, and then new stage. If we have a likely virulent inacute, less than 6 weeks, we can do a debride and irrigation or component exchange. This is, of course, one of the steps using the spacer. Likely indolent. In likely indolent, usually the score is less, is between 4 and 5, and according to the literature, 1 stage works very well. Unexpected post-operative culture is an issue. Usually the score is very low, 3, 4, that's the reason these are unexpected, and 1 stage and debridement. 2-step versus 1-step versus 2-step. If we look to the meta-analysis, the meta-analysis says that 1-step should be theoretically better than 2-step, 2-fold less reinfection, 3-fold less reinfection, 2-fold fewer complication. The goal of the preoperative antibiotics is to target most common shoulder spine space, achieve bacterial tissue concentration and incision. Recommendation is very well known. Timing of empiric treatment antibiotics with respect to the microbiological sampling. One goal is to a stabilization of the acutely septic patients. But in conclusion, any negative impact on cultures by giving prophylaxis on time must be weighted against the need to reduce the surgical site infection risk following revision on balance. Prophylaxis should be given on the time in most situations. Thank you.
Okay, next speaker, Ashish Gupta. Why and how do we perform a single-stage revision for infection?
My presentation doesn't have so many referees. So I'll just start as a precursor to this. I was always trained to do 2 stages or do multiple stages for the infections, and all these criteria came up, and it's a bit confusing for me personally. So I'll skip through this. So this is my diagnosis. For me, every infection is infected. Then this just keeps the whole algorithm really easy for me because I think everything's infected. So in 2018, I converted to a single stage for all the cases because my outcomes in my PROMS and PREM score for 2 or 3 stage infections wasn't good. We were putting a spacer in and we were, trying to come back and do stuff, but the glenoid grafts, the defects in the bone were much worse with spacers, and the post-operative outcome of these patients was very average, so I don't really know if I helped them. So my aim for this is to treat the infection and it's to restore function. Those are the 2 aims of the revision. It's a 2-step procedure for me. I debride, I explant, I tag the tendons and I dissect the plexus. And this takes 60% of the time. And in step 2, I come back, we re-prep, re-drape. I have a new team of scrub and scout nurses. We have new instruments and a new setup, and we do the operation. So I'll talk about my results. We've done like 25 cases in a single stage now. This is a slightly older slide. And out of these 17 cases, this is the spread. And all the infections were successfully cured, and I haven't had any instability till date. Mean forward elevation with a single stage compared to a 2-stage procedure for me, is 140 degrees of elevation, and I've managed to get an external rotation of 40 degrees, which was a challenge with 2-stage revisions for me. The hospital stay is reduced. I keep the patients in hospital for 2 weeks, so it's 16 days, and you can see that the patient satisfaction is much, much higher compared to a 2-stage undertaking. And in Australia, we've saved around $250,000 per case as well. So this is what my thing is. It's a team approach. We explant. We save all the soft tissue attachments. It's a soft tissue operation. I lavage and I wash out. Then after I wash out, I do a second look debridement. We put 2 grams of vancomycin powder. We close the wound and we go for lunch because it's been 3 or 4 hours and it's a long morning. In the meantime, then I decide whether or not, do we do implant retention or an explant? And this is the reason why we developed Reflect Complex, because of the need to be able to do single-stage revisions. And because you're able to plan this, and if the implants are malpositioned, then I will take the implant out. But if the implant is not malpositioned, then the glenoid base plate is sometimes taking the glenoid base plate, destroys a lot of the glenoid. And I will take the glenosphere out, I will take all the screws out, I will try and mobilize the base plate, but if the peg is really well fixed, I will leave the base plate as long as it's positioned well. All the cement needs to come out in the humerus, and the humeral stem needs to be changed. I stand by the principles of joint line restoration for the glenoid and humeral length restoration. I'm not saying it has to come back to that, but that's a marker for me as to what level of reconstruction I need. I'll come back to the last slide. So for me, it needs to be clean and you need to debride it till there's pepper pot bleeding. I was trained during my training by one of the surgeons who does a lot of osteomyelitis work, and he told me that when you're debriding an infection, you don't think about reconstruction, you just got to get all the gunk out. So I use a burr, I use a high-speed burr, and I keep burring the glenoid till I get pepper pot bleeding, and in the humerus, I just keep excising till it's absolutely clean. It's really important to identify the plexus for especially the young residents and fellows who are starting, because it's a nerve operation. You need to make sure your nerves are fine, so I use a nerve stimulator, and it's really important to tag all the tendons. Then in the step 2, we come back again, and we decide how we're going to reconstruct the glenoid. I've used allografts in infected cases, and so far I haven't had any problem, but metal augments are the other options. I personally never used a custom for an infection. I've had a case which had a custom for an infection with a trabecular metal which was really incorporated, and I can assure you that is a freaking nightmare. You have a custom implant with TM on the backside which is infected, and I didn't really know what to do with it. I left the implant as it is and just washed the shoulder out and changed the poly. Soft tissue is the key to prevent redislocation, and then it's dealer's choice whether APC or muscle. So this is lat dorsi and the teres major, which is a massive stabilizer for the shoulder. So I try and reconstruct this back every time. So just the last slides. This is my antibiotic protocol. This will vary from everybody across the world, but everybody stays in hospital for 2 weeks for IV therapy. In the meantime, I want the wound to heal up completely, and then based on the cultures, I'd like to give them 3 months of antibiotics. We start range of motion on day 1. I use an interscaling catheter, and we start physio. And generally, even with quite severe defects, you can get really good function with a single stage revision. Thank you.
Next speaker is Mr. Pitch, and he would teach us on why and how do I perform a 2-stage revision.
Thank you. It's like a mini battle. Okay, so I personally still think that the 2-stage does remain the gold standard, and I've seen that change in people's perception about single stage, and I think this probably is driven mainly from the hip surgery literature. Much as we published on periprosthetic fractures, the shoulder isn't really like the hip, not only in its biomechanics but also in the microbiology as well. And the only really well done RCT, which was the INFORM RCT, has really given us no concrete data on reinfection profiles, just on quality of life measures. So this is why I do a 2-stage revision. These patients have got severe infections, chronic sinus formation. Often we don't know the organism, but really high clinical suspicion of infection, or obviously having cultured maybe through sinuses of a virulent organism. But I also think that before learning about Ashish's new software, that actually the reason why our shoulder replacements are doing so much better is that attention to detail for preoperative planning. And obviously it's a lot easier once you've got everything out and you've got time to sit down and plan things. And also to deal with all of the soft tissue contractures you can get with those patients with chronic infection. So in our hospital, in our unit, 90% of our revisions are 2-stage. So it starts for me with a successful MDT. We meet every 2 weeks, looking at pre and post-op and then intermediate stage patients with all the appropriate staff. We really try hard to identify the organism. Starts off with an open aspiration, so prep and drape in theatre, open the wound, prep it again, then do your aspiration. If that doesn't give us the right answer, we'll do through arthroscopic biopsies, and obviously that helps inform our local antibiotics at that first stage. At the time of removal of the prosthesis, we'll try hard to take 5 samples, and as well as in anaerobic and aerobic blood culture bottles, we'll use a sampling pack, separate forceps, 5 separate knife blades into separate pots. I think meticulous debridement is probably the key to success of longer-term infection-free recovery. Very much like we say on distal humeral fractures, ensure you have enough time. If you're due to pick up your kids from school at the end of your operating session, you can't be rushing these cases. So we use an endoscopic technique for preparation of the humeral canal, and I think this is really, really useful. Quite often when you take out the implant and just give it a scrape, it looks really clean. When you get down there, it is dirty, and removing all of the cement pieces, all of the membrane, you can do real-time reaming with good visualization down the canal, and this has been really useful at getting that implant clean. We use a bespoke antibiotic spacer for that particular patient. So on the left, you'll see a preformed spacer that can work well, but if you look at the second spacer along, it's going to be a miserable second stage revision. The soft tissues are going to be in a state of how medialized it is. So we're often using this kind of resurfacing, the third one along type of antibiotic spacer. And then of course for those patients with severe bone loss, you just have to make it up on the day. This is a local infection process, and therefore you need local antibiotics. And if you look at the elution profile of your antibiotic spacer, particularly when you mix your own antibiotics with open bowl mixing, you've got a 17 times higher percentage elution than if you use IV antibiotics. And I think this is really important in success of resolution. They will also go home with 6 weeks of at-home IV antibiotics. Then you need to prepare for the second stage, and that doesn't always mean you're going to go and do a second stage reimplantation. So both clinical, microbiological and biochemical assessments, and they need an open and arthroscopic rebiopsy. And then if there's clinical suspicion or further infectious suspicion that they've still got something going on, we'll go and repeat the whole of the first stage. So a couple of cases to finish with. This is a patient that looked like he had aseptic loosening. We're a little bit worried about some of the early stages with this wound. It's clearly a not very well done prosthesis, but actually he was pretty happy for 7 years. So, but when we biopsied him, he had Cutibacterium acnes, and we prepared him for a 2-stage revision. He had a off-the-shelf gentamicin spacer, and we were able to, at the second stage, just do patch and bone graft for his second stage. This is a common failure mode for us with Steve Copeland's sort of massive resurfacing hemiarthroplasties. And in our experience, when you see this severe glean or erosion, it's almost always associated with a P. acnes infection. And of course it was in this case. And this is where we started playing with more bespoke cement spacers to try and make sure those soft tissues are amenable to second stage reimplantation. And this glenoid, for me, is unrecoverable without a custom. And he had a custom implant and is infection free at, I think, 4 years now. And the last case of a bit of a nightmare, poorly done fracture fixation, and I think this was 8 years ago. There was no tuberosity augmentation system available at that stage, so he had a cemented proud, and came back with what we thought was just plain old loosening on the humeral side because it was biomechanically unstable. But he had staph epidermidis. This is one I showed earlier. You have to make up your own cement spacers in bone loss. And then he repaired well with a humeral reconstruction prosthesis. So in conclusion, for me, 2-stage revision remains the gold standard, but we'll of course follow others doing single stage. I think you need an MDT well set up to track these patients, manage them appropriately, meticulous first stage debridement, and then repeat that first stage if needed. Thank you.
Thank you so much, Chris. So please, Jonathan Levy with preventing infection in revision shoulder arthroplasty.
Shoulder Center in Boca Raton, Florida, and I'll be talking to you about preventing infection in the setting of revision shoulder arthroplasty. Here's an overview of what I'm going to try to cover, understanding that prevention occurs before surgery, in the middle of surgery, and still after surgery. Keep in mind that the overall incidence of infection in the setting of a primary shoulder arthroplasty is around 4%. But if you've had a previous shoulder arthroplasty, the odds ratio of infection is almost 6-fold. We do know that there are higher rates of infection in younger males, and as well as arthroplasty done for trauma. The preoperative workup includes an appreciation of the clinical appearance, things like a draining sinus or pathognomonic for infection. labs like SED rate, CRP, and a white blood cell count, an aspiration, if you so choose, to look for white blood cell counts over 3,000, 80% or more polymorphonucleosides, as well as alpha-defensin. Imaging that shows evidence of humoral loosening is a big pathognomonic suspicion for infection, because humoral loosening in the setting of aseptic loosening it's extraordinarily rare. The International Congress came out with a scoring system, and you can place numbers to each of these potential preoperative workup in order to give a suspicion of whether you have a probable or possible prosthetic joint infection. In my hands, all my patients who are undergoing revision get a SED rate, CRP, and a white blood cell count. I get a CAT scan on every case, and I can appreciate humoral loosening, and if I'm suspicious during the surgery, I might aspirate. But I don't aspirate before surgery. I think it's such a high false negative rate that if I get a negative, I'm not sure if it's real, and if I get a positive, I don't know if it's a contaminant, because I really only have one specimen. Now, the night before surgery, I'll use a preoperative chlorhexidine bath. We do it the night before and the morning of, and this is what I give to my patients, a handout that kind of outlines how they should do it. Before surgery, I use preoperative antibiotics, Anseth and vancomycin, and I'll add Clinda and vancomycin if there's a documented penicillin allergy. And I do it within 30 minutes of incision, although technically we're encouraged to do it within an hour. Now, I don't hold antibiotics in the setting of revision. I think the hip and knee literature is pretty clear on this, and I think you can extrapolate it into the shoulder world. I'm more worried about contaminating the wound during the initial approach in the setting of a revision if I don't use antibiotics. Intraoperatively, when I bring the patient to the OR, they get a chlorhexidine wipe followed by 2 chloropreps. I culture when there's suspicion, but I don't culture every revision. And when I do, I get at least 5 specimens, and I hold them for 14 days to culture for Cunibacterium acnes. Intraoperative frozen section I'll use sparingly. I think you need a really good pathologist who understands what to look for, because you need 10 polymorphonucleosides for each high-power field and find it in 5 fields in order to be suspicious. I do use filtered hydrogen peroxide. This is done for me in a sterile hood by my pharmacy, but it can be done using a 0.22 micron filter. And then, once you have it, I apply it to the dermis after the incision, and I use it to clean instruments that have touched the dermis during and throughout the case. There are a variety of different irrigation and powders that people use. Basi Poly is the classic, although it's never shown to benefit. Sterile providine iodine as a dilute betadine wash in a soak is really popular in the hip and knee literature. Chlorhexidine is gaining more popularity. Hydrogen peroxide has a broad base activity for bacteria and yeast, can work as a mechanical debridement effect, and has a great hemostatic effect as well. And it tends to be synergistic with providine iodine, and as I mentioned, it's something that I use quite often. Vancomycin powder, the data is really extrapolated from the spine literature, but has become really popular in hip and knee arthroplasty. I haven't adopted it routinely, but in suspicious revisions, I will use a vancomycin powder at closure. I use a tremendous amount of irrigation, and I do like to use pulse irrigation. I add dilute peroxide combined with providine iodine, and I do it in a dilute fashion into the pulse irrigation as I'm doing it. And then vancomycin powder when I need it, and in most revisions that have any level of suspicion, I will. Post-operatively, I will use post-operative prophylactic antibiotics as a standard. Whether I suspect infection or not, they get 7 days of doxycycline. And it especially is useful for my younger males in hopes that it might prevent C. acnes. But if there is an infection suspected and I've taken cultures and I have concerns, I'll place a patient on IV antibiotics for 14 days until the cultures are final, and I'll involve an infectious disease specialist to help guide me on the antibiotics and make sure that it gets appropriate antibiotic dosing throughout the recovery. I encourage you all to read the consensus statements that were created by the International Congress. Definite prosthetic joint infections are clearly defined by a sinus tract to the prosthesis, a gross intra-articular purulence, or 2 positive cultures with a phenotypically identical virulent organism. These are the harder ones, which are the ones that are where you suspect a probable or possible joint infection, and there's a great scoring score that you can use to understand what things might raise your suspicion of an underlying infection. Thank you so much, and I sure wish I was in Rome with y'all.
Next speaker, Dr. De Carli. We change subject now. Defining the risk factors for instability.
Thank you, Francesco, for the invitation and for the beautiful Congress. Defining the shoulder prosthetic instability is an excessive movement of the prosthetic components resulting in dislocation or symptoms of instability. We know in total there is amount of 5% and a wide range in reverse from 1 to 31. The causes are infection or mechanical failure, impingement, notching, loosening of glenoid or poor tissue tensioning. How to manage the instability? It means to evaluate the cause with a comparative X-ray, a CT scan, and laboratory exam in order to investigate humeral shortening or humeral or glenoid medialization, implant orientation, fatty infiltration of rotator cuff, or biological assessment to correct the cause of instability. Pascal Boileau in 2015 say that on reverse, prosthetic instability occurs in 38% of cases. And risk factors are previous surgery, deltopectoral approach in his experience, 10% versus 0 in superolateral deltoid, cam effect in obese patient for humeral malunion, bone loss with the humeral or glenoid side, and soft tissue deficiency. Patient at risk are with shortened humerus for implant migration, greater tuberosity lysis, and humeral resection for tumor, or hemi failing to restore the humeral length, or glenoid medialization with the glenoid bone defect or a small glenosphere. And implant malpositioning play a role too in horizontal or vertical plane. And Jean Walsh, in this series of over 1,000 patients, say that instability occurs in 3% of cases, and predisposing factors are younger age, revision surgery, no bony lateralization, scapular notching, and greater tuberosity resorption. And he concludes that the revision occurs in 70% of the patient with instability. In this larger series of patients, revision is only 5% and in less than 6 months after the primary operation. In another large series, 4% incidence of dislocation, these authors say that implant-specific risk factor appear avoidable with the current knowledge, implant design, and technology help. And superior base inclination too is a high risk factor. In this area, in 13% of cases, a superior base inclination increases inferior impingement, which leads to instability. What about total shoulder arthroplasty? Play a role rotator cuff tears, component malposition, dissociation, so loosening, and humeral shortening. In this case, the instability occurs in 5%, and the causes are mainly the soft tissue, 10 isolated subscap tears, 6 massive rotator cuff tear, and other, and timing early in most of patients, before 6 months. In conclusion, the major cause of instability in this series was soft tissue deficiency. And even when we look at the previous surgery that yields a worst outcome in total shoulder arthroplasty. And when we convert a total to reverse, revision is a good option, but 1 on 7 is a patient with a recurrent dislocation. So precaution in risk patients are larger glenospheres and increasing lateral offset. And in conclusion, these other studies are different from Australian to American Kaiser Permanent Registry due to instability, range from 31 in Australia and 12, 13 in Kaiser, and revision due to failure to one specific prosthesis which has been discontinued in Australia. And at the last, when we have a comparison between total and reverse shoulder, we know that a major complication, dislocation, is when we treat a patient before 50 years old, and in particular in reverse total shoulder arthroplasty. And it means that we can consider this fact in the future. Thank you.
Thank you, Angelo. Next speaker is Stefano Di Fabio, Management of Total Shoulder Arthroplasty Instability.
So thank Francesco for this kind of invitation, and congratulations on this great course. So my talk is about the management of total shoulder arthroplasty instability. Sorry. So as you know, the main reasons of failure of total shoulder arthroplasty are instability, glenoid loosening, and rotator cuff pathology. Talking about the instability, in most of the cases is due to soft tissues improper soft tissue balancing and component malposition. So, talking about the instability, the classification of the instability is in respect to the direction, the stability, and the etiology. In case of the anterior instability, usually is due to a subscapularis insufficiency. In case of posterior instability, it depends on a component malposition, posterior bone loss, and posterior cuff dysfunction, plus minor capsular laxity. And finally, in case of the superior instability of the shoulder replacement, usually is due to rotator cuff failure. So, talking about the management of the instability of the total shoulder replacement, in case of the acute means within 6 weeks without degenerative changes in the subscapularis muscle, we can try to repair. We can try to repair the subscapularis, changing, if you need it, the size, reducing the size of the humeral head, but we need to be ready to convert the implant intraoperatorily from anatomic to reverse if the subscapularis is not possible to repair. But in case of the chronic degenerative failure of the subscapularis, the only option is to convert to a reverse. In case of posterior instability, first of all, we need to put the component in the right position. So we have to correct the glenoid retroversion. And to achieve this goal, we have different options. First of all, we can do just an eccentric reaming. You need to do that if you have more than 10 degrees of retroversion. Otherwise, we put the glenoid component in the wrong position, so it's posterior orientated, and we can break the anterior wall of the glenoid. We have to keep in mind the relationship between the amount of bone that you have to remove and the degree of the retroversion that you have to correct. The ratio is 2:1, so if we have to correct 20 degree of retroversion, we have to remove 10 millimeters of bone, the glenoid bone. So you have to keep in mind this. So the other option to use the metal to correct the defect, and the other option and to use the bone graft, symmetric or asymmetric bone graft. Of course, we can choose a different side of the humeral head and we can change the retroversion. When we have to check the correct position of the humeral component, if it is still unstable, the shoulder replacement, we can do, as Giovanni said before, this morning, we can do a posterior capsular application, so try to repair and to reduce the volume of the capsule. But if it is still unstable, if it's a chronic posterior unstable, there is just the case where we can do a posterior bone block, but it's quite aggressive, like a procedure. But the safest option is to convert in reverse. And again, in case of a superior instability, is due to a rotator cuff failure, so we can have degenerative massive cuff failure, so we have to convert in reverse. So looking at the scientific literature, you can see we're starting from 2030 to talk about reverse as an option to solve this problem with instability. Of course, you need a complete modular shoulder system to treat this problem. So if you got a system, you're allowed to treat the instability without removing the hardware, so the gland component, you can change our plan even intra-op. So if I'm not sure about the stability of the implant during the operation because it's not stable enough, so intraoperatively I can change my idea, so I can switch, just remove the insert in biology, used a gleno adapter, and then I put a glenosphere and convert my system with anatomy. Like in this case, we got a static anterior unstable shoulder replacement. And we can do the revision like, without removing the hardware. So, in conclusion, first of all, the main important things to do is to prevent the instability with the correct period planning, with a meticulous dissection and proper implant position, and with a strong and effective subscapulary repair. But if you have to revise, the safest option is to do a reverse. Thanks.
So next speaker again, Chris Pitch, and he will teach us how to deal with instability after reverse.
Thank you again, Francesco, for your invitation and another tricky topic. So I'm going to introduce you to some greats from English greats of preventative medicine. And following a theme this afternoon is probably that Sir Edward Jenner and John Snow, who are influential preventive medical persons in England, is that prevention of instability is probably better than the cure. So I guess the good news about primary instability of reverse shoulder arthroplasty is that it's pretty rare, and it's getting rarer. Pascal Boileau presented their theories noting a significant reduction from the first 10 years to the second 10 years. And that probably reflects all of our learning curves in doing this procedure. So let's just look at two sets of big data on this. We've got the Exactech group that we put in data for, 5,500 patients with a 1% dislocation rate. And they helpfully outline those at-risk groups, males, high BMI in previous open surgery. And this probably lets us know how it's prosthetic dependent. The Gramont-style prosthesis in almost 2,000 shoulders with a 3% dislocation rate. But again, a useful risk factor profile in males, those who are younger, early in the learning curve for the surgeons, in revision cases, of course, but then this protective effect of the bio-RSA. What was interesting in the Exactech study was the comment on the subscapularis repair, because obviously in this prosthesis, subscapularis repair is much less frequently carried out, but showing that the protective effect in the females with repaired was the lowest redislocation group, whereas in the males with no subscat repair was in the highest group. We need to be aware of those surgical factors that are going to contribute to instability, not only so we prevent them happening first off, but we recognize them when we're trying to manage it. So superior inclination of the base plate, and then all of our soft tissue elements. So resection or absence of the tuberosities, dysfunction of the deltoid, subscapularis insufficiency, and then careful attention to humeral shortening or lack of restoration of it, and then bony impingement. So when we talk about later about success with more simple methods, it's important to know when this occurs, early in almost half of the patients, and then there's a prosthetic difference as to when the rest occurs. And I think if you look at the early literature on dislocations, I think it probably shows that we have got better at avoiding more of the early dislocations. So this is how we're going to stepwise manage these dislocations. First of all, reducing that risk. You need to know your prosthesis. As I alluded to, the prosthetic designs are individually predictive of different kinds of reasons for instability. We need to be careful preoperatively planning. Now, that's not just assessing and redressing the bony defects, but using big data and computer learning such as Predict Plus, looking at those high-risk groups, as well as planning and correcting humeral shortening. I will do a subscapularis repair on a case-by-case basis if I think they're high risk. Fractures will do really meticulous tuberosity reconstruction and now tuberosity replacement. And that really difficult, dark art of assessing the tension, and a lot of us have been discussing that these last 2 days, and I still don't think we know how to do it properly. So if I see a patient with a dislocated reverse, they'll first off start with a closed reduction. If seen early in the first month, you've probably got about a 60% chance of success. We'll stick them in an abduction brace. But you've got to be open and honest with your patient. If they present more than a month after surgery, you've got a 2 out of 3 chance of redislocating. So this is not for revision cases. Then we need to take them to theatre and probably first off try some fairly simple procedures, some easy wins. Look for bony impingement. Look at the tuberosities, have they migrated, look at bony impingement on the glenoid, try and address the humeral length mismatch through liners, and consider using a constrained prosthesis. But of course, it's futile to completely ignore really, really bad mistakes done at the first operation, so don't skive off addressing those. And a lot of the patients will stabilise after those very simple procedures. And if they don't, then you can move on to the big one. And a full revision, you've got to go into theatre with lots of plans, all of the kit. Be prepared to completely revise the orientation of the glenoid, as well as just address the size, address the humerus. And I think also pay careful attention to the soft tissues. We do an imbrication and closure of the delta pectoral interval. And I don't think we properly understand the role of tendon transfers. Just a couple of cases before we finish. This is a probably poorly done fracture reverse. The tuberosity is migrating and then dislocates. And at the time of surgery, she had a cam effect on the tuberosity fragment at the back of the humerus. We did some simple manoeuvres, excise that, change it to a constrained liner, and she was stable. Second case is a failed fracture fixation 7 or 8 years ago. Similar case to the one I showed in the infection. This patient had no option for tuberosity augmentation at the time, and then presented with late onset dislocation. And at the time of surgery, you see that this more often in those later dislocations with that impingement and loss of that medial buttress of the liner. So conclusion, we've got to prevent, that's obviously the best cure. Consider increasing the constraint for your at-risk groups in that prevention. Attempt to close reduction unless it's obviously futile, and then have all of options available for revision.
Okay, so let's start with discussion. We decide to do the discussion with the first 2 presentations. So please, Giuseppe and Giovanni, as you prefer.
The microphone here.
So one question to Giuseppe. I definitely agree with you that because of the different causative germs, we have to add different diagnostic criteria for arthroplasty in comparison to. However, in looking at your workout, that is, you still use the bone scan. Can you comment on this topic as for the shoulder arthroplasty, please?
Yeah, thank you very much. The indication is very limited for bone scan. But still can give us, because the consensus also there was no agreement on the use of bone scan, so I would say that it's not useful. However, when you have still the high suspicion that there is an infection, we still perform the bone scan with leukocyte, so, but it's arguable. I don't think that we can reach an agreement with on this. Thank you.
I have a question for both. You say that in Italian experience and even in literature, the rate of infection is about 5-6%. But we know that the painful shoulder after a reverse is much higher. So do you think that we overestimate or underestimate the role of infection? We are not able to find any proof of infection in all the painful reverse, or probably not all the painful reverse are infected?
Very quickly, the percentage that I presented is referred to the codification of our SDO, which is the Italian system for codification with the ICD-10. So sometimes there is an error of codification. Sometimes there is an error because we keep when you want to isolate Cutinobacterium, Propionobacterium, you need at least 5, 6, 10 days of incubation of the cultures, and we know that in the past, after 2-3 days, if it was negative for Staphylococcus, this was not considered infection. So we know that a lot of the painful, stiff shoulder that we see in our clinic, now we understand, now we have learned that these are infection from low bacteria, but I think that as the percentage refer also to cases in the past, these were not codified.
First of all, I think that is underestimated. But regarding the painful shoulder after reverse arthroplasty is very complex. We should do a meeting on this. I think we have to see why we did a reverse arthroplasty. For example, in my personal experience, are more painful the patient that had a previous surgery like a calf repair. For some reason that is not clear in my experience, but if I have to make an average, they have a little more pain. But it's very complex to find the source of pain, and I think that also cervical spine problem can influence sometimes because they change the posture. So it depends how old is the patient, the posture of the patient. So there are so many factors.
Any other questions? Okay, so there's one question in the back, please. This is the last one for these two speakers.
I want to know if you have experience the treatment of the infection for about stimulant that are used in hip and knee infection.
Actually, it's a good idea. It's possible to use it, but I personally don't have experience in this.
Me neither. Okay.
Thank you so much.
Thank you very much. So we'll bring to the podium Chris Pitch and Ashish, and we will discuss 1 or 2 stages. Any questions from the audience? Jay?
Yeah, no, it's really good.
Yes, a question for Ashish.
Yes.
So you presented your preliminary data. So the bacteria of etiology really pays no difference to you. You still do a single stage if it's C. acnes versus strep or staph species.
Yeah, so I haven't had any E. coli or enterococcus grow in the shoulder, and I think if you have really virulent bugs like that, then I think single stage might be a bit dicey. But till date, I haven't had any E. coli or enterococcus. Almost everyone is C. acnes, and I've had a few staph epis as well and staph aureus, but I've done them all single stage.
I think in the States, that seems to be one of the distinctions. Some surgeons will single stage if it's less virulent and 2 stage if it's more virulent.
And I've even looked at them, like I've done quite a few who had open sinuses and open fistulas. I've had wounds which are open by 6 centimeters, and a guy came with a colostomy bag over it, and all sorts of stuff of that sort, and I've done them all in single stage.
You also said something in your talk that you will sometimes retain a well-fixed base plate in the presence of a single stage. Can you elaborate on that?
So
you could not do that in the U.S.
I was really scared about that, and I talked to Luc Favre and Ludwig about it, and I leaned on their experience because I don't have enough runs on the board. And this was the question where, the humerus, you can pull stuff out, but in the glenoid, if the peg is really well fixed, especially in like a delta extend or something, then I asked Luke that, if I remove this, I'm going to destroy the glenoid and we'll have a bigger problem. And Luke and Ludwig's philosophy is that if the peg is really well incorporated, and there isn't anything behind the base plate, then it's not infected all the way down there. So what I do is, as I said, that I'll take all the screws out, and I use a 90-degree saw, which we use for the lattice to cut the lattice. I use that and I run that around the base plate, behind the base plate. And then I curate everything out, and then I put the inserter of the base plate and really try and twist and tap and pull it out. And if it comes out, hallelujah. But if it's not coming out, then you really have to, and if the implant's not malpositioned, so that's another big factor, I will leave it.
We need to move, just one question to Chris. Chris, how often after removal of the implant, your patient does not want to have another operation? Is that something that happens in your practice? Or?
Yeah, so I've not encountered that often in the shoulder. I mean, we published on the sort of almost 2/3 of the patients with certain types of revisions in the elbow not coming back for a second stage. I've not come across it in the shoulder, and it probably reflects it's not that's stable enough of a joint to get that function.
Okay.
Yeah, I think that the off-the-shelf spaces are pretty poor for the
Short comment, Howard. Short
comment. Question for Ashish. The window of time when you're doing this single stage, where you said that you close the patient up and you go to lunch, were you serious about going to lunch? Or
Yeah.
were you, all right. So you you close the patient. You don't close the skin all the way.
I just use running nylon.
Okay.
I use running nylon and I close everything. I put a combine or a pack on it and put some opside or betadine drape on it. And because the whole procedure takes 6 or 7 hours, like for me, debridement, removal, washout is 3 hours, and then recon's like 90 minutes to 2 hours. So we do, and also I found out that the re-prep and re-drape and the new instrumentation kit which needs to come in takes 20 minutes. So that's the only time I have a proper Coke and not a Diet Coke.
Thank you.
Okay. And does your type of food influence the results or not?
No.
I think the fellows influence the result.
Okay.
Sorry, no more questions for. Sorry. Three following speakers.
Chris, stay here.
De Carli, Di Fabio, and Peach for instability. We have time for 2 questions. Is one question, Raffaele?
It's for Fabio. Fabio, do you think that modifying the orientation of the glenoid or making an posterior capsuloplasty is sure that the anatomical shoulders can be stable?
I don't. I just read the case report, but I never done a capsule application for the posterior instability during the anatomic shoulder replacement. The point is, what happens, it is my experience, when you put all the components, and I try to do what Giovanni said this morning, the trial to test the stability. So you have to be able to posterior subluxate the humeral head, and they have to come back by itself. Okay, this is the trial we use to check the stability. But the point is, the only things that I do is, if I had too much posterior instability, I try to change the humeral head a little bit bigger, and then I try again the trial. But if it's still unstable, and I think I'm quite sure about the correct position of the component, I switch to reverse.
Any other? So 2 very quick questions, 1 for each. Choose who want to reply. Do you think that, how do you evaluate tension during procedure? And the second one is, do you think that changing humeral version can solve the issue of instability in reverse?
Sorry, another question about the anesthesia. When you check the stability of the implant, how can you judge the anesthesia of the patient?
Yeah, so I alluded to, I think it's a really, really difficult thing to do. So I think we're all doing our own things and probably think it works in our own hands. So what I do, and when I was training, I used the delta prosthesis, and I was taught to put it in really tight. You pluck the coracobrachialis and want to hear a noise. With the exact prosthesis, putting it a lot looser. So interoperatively, I'm looking at when it's reduced, and I'm taking them out into about 60 degrees external rotation. I want to see tracking of the humeral liner without any gapping at all. And if there is, then I'll go back and do more soft tissue releases, because it's probably impingement. And if I do that and it's tracking fine, then I'm happy. And as long as I can't take it out with a finger, then that's my two ways of checking. And then if I can, then I'll go up on the liner.
For me, it's important the pre-op planning and try to have the size of the defect that we are checking for, and test the tension of conjoined tendon, not the longette of biceps, as you see before. And after you have considered you have to lateralize on other, but you can plan everything. You can have the chance in the operating room to change or vary something that, in my experience, is often that the plan is a little bit different from the reality, because we have soft tissue. We can predict exactly the tension at the end of the procedure.
Thank you very much. So
Thank you so much.
Thank you so much. Giovanni, it's your turn. You're with the panel.
Thank you. Please, Angelo. Please. The first case, please. Angelo, Antuna, and McBride. So we have different cases. The first one is infection case. Può mandare? Thank you. This is a patient that is 72 years old. She was operated in 2019 in another hospital with this kind of surgery. Then she was painful. She referred to me because she was not my patient at that time, that she was painful, not good range of motion. So the same surgeon performed this surgery in 2020. But she did improve. And she came to my observation with this situation. It's the right shoulder. The movement is not so bad. She has discomfort. She's not happy. She's painful. So I asked for the X-ray. This is the X-ray. So my first question here is, the good range of motion is enough good. She is painful, but she's not in a dramatic situation of pain. But this is the X-ray. Which is your position? Do you follow the clinical finding or do you follow the X-ray? Please, McBride. Please, the volume. Yeah, thank you.
Yeah, I definitely treat the patient and not the X-ray. So I'd be watching her closely with serial X-rays every 3 months. And I just wanted to quantify her pain level. So does she have night pain, or is it constant pain through the day? Is she able to do her basic activities of daily living, such as cooking, cleaning, and attending to her personal hygiene? And if she has a low level of pain and she can do all those things, then I'd have a discussion with her about the alternative option, which would be a huge operation. And I'd make the decision with her, but I think I'd be inclined to watch her over time.
Thank you. Dr. Antuna, what is your position with this patient that is painful, but she has discomfort, but she's not terrific?
Yeah, she will be, and I know she will be. So for me, this is a case in which I would try to convince her that she needs something done, even though this is a tremendous operation, because you're going to be worse soon. So if it was the opposite, maybe I would consider, if she was painless, no pain at all, and the motion was limited, then I would probably wait. But if she's painful, there is this radiographic signs of infection, the chances of improving are, in my mind, none.
All the blood tests for infection were completely negative. Blood tests. Angelo, what is your position with this X-ray and clinical finding?
I completely respect more than radiographic aspect, the clinical aspect. So the range of motion is not so bad and the pace is not severe. I say it's possible to wait, but my feelings is that something you are going to pay with this situation. So it's very difficult to say wait and watch.
So I agree completely with you. I had a nice talk with the patient. At the end of the game, she decided to have surgery. And this, I have different video on the surgery. So the first step is to remove the stem. Until here, I'm so lucky, happy. Very happy at this point. Very easy. And then here begin the bad day. Okay? So as was told this morning, we try to respect the proximal humerus to save the bone. And we try different, Dr. Palladini said, different technique to remove the stem that was cemented. Fortunately, we are ready for everything. Of course, otherwise you can face this kind of surgery. And then we switch to a window. Do you agree with this algorithm, or do you have some other option before doing a so large window?
Yeah, I think on the preoperative X-rays, the stem looked well fixed. So I guess our approach is to use curved osteotomes and K-wires from the top and remove the metaphyseal bone around the stem, and then we sort of work in a stepwise fashion, creating a linear osteotomy and then extending that to an L if required. And then we just very carefully try and open the linear osteotomy, and if the stem comes out, great, and if it doesn't, then we extend it to the L, which means a bigger osteotomy.
And then, Dr. Antuna, which is the final osteotomy? Is inferior to the cement line, or do you do at the level of the prosthesis? Which is your rationale to extend distally the osteotomy?
Well, it depends where the cement is. If the cement, I mean, in this stem, you cannot just go all the way down because the stem is so long.
Exactly.
If the stem is a standard stem, and I needed an osteotomy, I don't struggle. I go farther down and remove the cement easily. If it is a very long stem, then I would just try to play around distally. But it depends on the size of the stem.
Okay, thank you. So after fighting a little, we remove the stem. So now we go, just to respect the pectoralis major, as was told, is very, very important. And then we go proximally. We remove the glenosphere. And we found what we expected. This is the base plate removal. And what about the screw? If you have in mind the X-ray, otherwise I show you again the X-ray. There are the tips of the screws that are broken and are into the bone. Because the risk of unexpected infection, do you look for all the tips, and you try to remove the tips of the screw, or you respect the bone and you leave the tips of the screw into the bone?
I think it's a tightrope balancing act. I try and remove all the metal, but at the same time, you don't want to remove the entire glenoid vault. So I think I take a practical approach and remove as much metal as possible. If there's a screw that's deep in the bone that I think is likely in a non-infected area, then I may leave it, but I try and remove all the metal where possible.
Dr. Tuna, what about
removal? Basically the same. If the screw is deep inside the glenoid,
Yeah,
and
exactly.
in order to remove that, it's gonna ruin the glenoid. I will probably take the chance of leaving that part of the screw, but it's easier to remove. I will go for it.
And Angelo, of course, in this case, the suspicion of infection is real. And what kind? Where did you take the specimens? In which part of the shoulder did you take 4 or 5 specimens to be studied?
We can take from the remaining tissue, and especially when do you see the major reaction of the tissue, so all around the proximal humeral and the glenoid component, anterior and posterior, and when you see the real problem.
Regarding the spacer, also in the literature, we are very precise when we speak about the anatomic prosthesis stem, the reverse prosthesis stem regarding the position. Which is the position of this kind of tool? Is you want high, you want low, you want centered with the glenoid? There is some rationale behind the positioning of the spacer, or you put the spacer as it happened, or do you follow some rule?
Maybe the most important thing maybe is the version. You can sew dynamically when you finish the position if you are happy with the 20-30 degree or retroversion, and see as you feel that it is stable.
Dr. Bright, how do you stabilize the stem in this? With some cement? Do you use press fit? What kind of stabilization do you want to achieve? Please, voice.
I use an off-the-shelf stem that's prefabricated, and it comes in 3 sizes. And it's cemented, and it's just cemented proximally around the metaphyseal region, so I don't put the stem down into the canal. And then it's stabilised by the cement and also the soft tissue rebalancing. So obviously try and recreate the native humeral version, and then obviously closing, try and repair what I can of the soft tissue structures across the front.
Tuna, can you comment this X-ray regarding the height of the spacer? We left some cement distal to the spacer and the 2 tips of the screw. Which is your thought? Are you satisfied with this X-ray, or you would expect something different?
I am extremely satisfied with this X-ray, especially because it's yours and your patient. But I think the spacer is in the perfect position.
Thank you.
I would have done the same with those screws for sure. I would not pursue removing those screws, and I may have. I would be probably happier if there was no such amount of cement distally. But I've been in this situation, and I've seen X-rays of my cases like this. So that's let's hope for the best for this part. But yeah, I think regarding the spacer, this one looks great. I just use a small amount of cement proximally with blue methylene, so when I remove it, it's easy.
Angelo.
Giovanni, one extremely satisfying spacer. In my career, I remember were patients that after this procedure healed after 6 months and not a good movement, but no pain, no infection, and she didn't want to take a revision, and she is happy after 3 years with the spacer.
There is only one big error that I did. That I did this surgery in the middle of August, you know? In the August in Italy is summertime. Usually we should have holidays. And I did the biology. This is Staphylococcus was present. So we began some antibiotics, and after a few days, this is the picture. So the patient was surprised. I was surprised. I tried to do my best also with the huge debris. I spent more than 1 hour, maybe 2 hours to do the debris around everything. And she was under antibiotics, and this is the situation. Do you have some kind of experience of reinfection with a spacer? And please, how do you handle this patient?
Yes, I've never had a sinus to that degree with a spacer. I've had a spacer exchange that's come back with positive samples. So this clearly needs to have a large operation. There's soft tissue and bony considerations, but obviously removing the scar from the start, removing the sinus, any signs of infected tissue on the way in, and then I'd do a spacer exchange, a repeat first stage, and then repeat debridement and send new samples, and then come back and treat the patient again.
So your advice is to make surgery immediately, in this case?
On this case, looking at that, I would go straight into a...
Yes. It's very uncommon, so...
Repeat first stage.
Perfect. Dr. Antuna, what is your behavior in this case?
A
few weeks, maybe 2-3 weeks after the surgery.
So this is a very uncommon situation, I must say, and I mean, you have not been able to help the patient for any reason. So this patient will never be better if you don't do anything. So you need to do something. So in my hands, this patient would be probably go to the OR again, get the spacer removed, not use the spacer again, try to, if I can, remove more cement, and that's it. I don't know the reason why, and then took samples again. I don't know the reason why this is happening. This maybe there is another organism that was not diagnosed. Maybe there was the spacer itself was contaminated intraoperatively and got infected, and but he needs another operation in my hands.
Angelo, what will you do? Will you wait and see, or just acting?
No, I believe it's unusual, this situation, but I believe it is better to proceed as soon as possible, because we at our hospital have a bad experience with leaving the patients in the hands of the infection disease specialists, because after 2 or 3 months of antibiotics you can find destroying medullary cilia in the blood, and after compromise the possibility to have the second surgery. So it's better to, maybe it's a problem in laboratory of this, in recognizing the bacteria.
I took a different decision. That's the reason I spent an horrible August last year. And so I used the band with negative pressure. I followed the patient every 3 days. She was very compliant. She proceeded with antibiotics. And now she's fine. She's happy. She's not ready for a revision. I am less ready than her to make a revision, of course. But she feels comfortable. She is happy. She is improving, but no more than...
How many days of vacuum therapy?
Maybe 4-6 weeks long. Okay. Now the second case, please.
No, Giovanni,
Okay.
we are out of time.
Sorry.
It was really very interesting in this case. Congratulations.